everyone. Thank you very much. Go ahead.
Hello, Dr. Amri. Happy
أهلا
to see
دكتور
you
سعيد،
all.
مرحبا. سامة، دكتور مهدي,
أهلا دكتور
everyone.
عمري. أهلا.
وليد مرحبا.
Yes,
Okay, Farzad, the mic with you.
So, good evening, and thank you for joining us in the Occuloplasty Session 1 in QIC conference. Thanks to Dr. Mohammad for being at this wonderful meeting. So we are going to start the oculoplastic session today. And so the first speaker is me, and I may start my presentation. So in this session, each of our dear speakers will show us some cases with some learning points. So please let me know if I'm visible.
Yes, Dr. Farzad, yes, please, you are okay. Just I request all dear others to mute themselves. Thank you.
So I'm going to start my presentation. This is a case with some interesting learning points in it that I hope that our colleagues enjoy. And after we have all presentations, we have some time for discussions and answering the questions. So here I would like to ask all my dear colleagues and friends to keep the time. So I will start my case. I have no conflict of interest. My case was a 32-year-old man with epiphora and discharge in both eyes. He had a history of acute lymphoblastic lymphoma 11 years ago that was treated with chemotherapy and no recurrence after that. He's non-smoker. He had history of external DCR in both eyes last year for epiphora and discharge, but after a while, he developed again the symptoms of discharge and epiphora in both eyes. So in the last month, he had history of acute dacryocystitis in the left side that was treated with coamoxiclav and resolution of the cellulitis. This is the basic ophthalmic examinations. You may see that the positive points that are highlighted as red shows that we had positive irrigation tests in both sides, and we had a slight limitation in adduction in the left side. So as this was a young man with epiphora and discharge in both sides, I asked for CT scan, and in the CT scan, you may see that we have ethmoid sinus opacification and loss of the bony architecture of the both ethmoid sinus and the medial wall of the orbit in both sides. We have enlargement of the medial rectus muscles in both sides. And we have clinical features of recent actual cystarenostomine on both sides. So based on that, I decided to perform a sinus biopsy. And although in my practice, it's essential to do endoscopic nasal examination for every case with epiphora. And so you may see that when I enter the nasal cavity, I'm seeing inflamed mucosa, I'm seeing retained silicone tube from the previous surgery there. You may see that we have crossed and actually pus overlying swollen and brittle nasal mucosa over there. And we have loss of septum. You may see that when I touch the septum, it's just mucosa. There is no bone under that. So based on that, I assume we are dealing with some necrotizing inflammation. I asked for pathologist report on that. You may see here in H&E staining, we are seeing a mixed lymphocytic and polymorphonuclear infiltration. If I can show you here, you may see we have vasculitis in the center of the actual scene. We have inflammation of the vessel here, occluded vessel here, denoting its small vessel vasculitis over here. So this is another part of that tissue sample. You may see that we have mixed lymphocytic and some area we have polymorphonuclear lymphocytes. And actually, it's a background of the fibroblastic activity over here. So it's highly suggestive for PGA, formerly known as Wegener's granulomatosis. So I asked for more lab tests. You may see that we had PR3 positive titer here. So we could confirm the patient has GPA, Wegener's granulomatosis. We started more actual evaluations. You may see that in the chest CT scan, we have cavitary lesions on the right side of the lung here. And we asked our rheumatologist to start treatment. He underwent treatment with methylprednisolone pulse therapy and cyclophosphamide. So then after a resolution of the actually active inflammation, we did endonasal endoscopic DCR for the patient with resolution of all symptoms in the next 15 months. So a few quick learning points here. In a young patient, especially when it's bilateral, we need to work up the patient for secondary causes of nasolacrimal duct obstructions, although we have no actually systemic or ophthalmic feature of any other disease. So for GPA, it's essential to understand that this is a multi-system disease. So we should look for any site that can be affected by this disease, not just upper inflammation or orbit. We should look at the lung, kidneys, or other regions. So we know that about 50% of patients with GPA may develop some orbital actually involvement. And among them, we know that in about 7% of patients, nasal lacrimal duct or lacrimal excretory duct system may be affected in these patients. And amazingly, this can be the first feature of this disease. So every ophthalmologist should be familiar with these symptoms and actually think about that. Otherwise, you cannot actually diagnose the patient on time. So usually lacrimal surgery in the early stages is associated with high failure rate because of the inflammation. After the inflammation is subsided, we can go for ductal rhinostomy. My preference is endoscopic job, and although we can do both external and endoscopic things for these patients. So thank you for attention. We'll be happy to have your questions in the actually at the end of the presentations. Thank you very much. So I may invite our colleagues to share their slides.
Good afternoon, everybody. So I guess I'm next in line. So I will share my screen now. I'm logged in from my laptop and also from my desktop, but I will use the desktop because of more stable connection. Another issue we can discuss, or we might have discussion during the case, because this is a strange case that I faced last year. So let's start, okay? So is it really a dacryo seal? So my patient, or this patient, is a 55 years old male patient, previously healthy, who was presented for the first time for me in the 1st of August.
Sorry, Dr. Osama. Sorry.
Yes.
We are hearing some echoes, Dr. Osama. I'm not sure if you have two devices on. I mean,
yes, I have two devices.
Can you please mute one of those, please? Thank you.
Is it better now?
Yeah, it's better
Yes.
now. Thank you.
Okay, sorry. The other device, the laptop, was the second device. Okay, so a 55 years old male patient, previously healthy, presented for the first time to our clinic 2 years ago almost, complaining of right eye tearing of a few months duration. His best corrected visual acuity was 6.6 in both eyes. Anterior segment examination was normal, except for an increase in both eyes. So the patient was treated for blepharitis. The tearing was minimal and was instructed to do lid hygienes and return for follow-up. The patient came 7 months later, early last year, in 22nd of February, complaining from a right medial canthus swelling for the last 2 to 3 weeks duration. The swelling was not tender, not inflamed, and upon pressure on this proposed lacrimal sac, no regurgitation of mucopurulent material came out. So we assume the diagnosis here is the mass lesion again or the swelling again. So we assumed the patient to have dacryoceal, and he was given an appointment for right DCR 3 months later. So as we see many patients, like this every time and then in the clinic. So on the day of surgery, the surgery was done under general anesthesia. The patient was draped in the usual manner. Skin incision was marked 11 millimeter medial to the medial canthus. Local anesthesia injected into the surgical field, and nasal pads were inserted into the nose. Immediately after skin incision, here is the skin incision, I noticed a whitish mass underlying the skin. So I stopped and said, what is this mass? Doesn't look normal to me, as I did too many external DCRs, and this is the first time I see such a thing. So I continued dissection, and later on, I found a mass lesion overlying the lacrimal sac. Here we can see the mass lesion, a well-circumscribed mass overlying the lacrimal sac. So I elected to take this mass out and did complete excision of this lesion, as we can see here in these. And then I managed to take the whole mass completely out. I did not know what this mass is. And of course, I didn't have a preoperative CT scan or any imaging study for this patient. So at this time, I stopped a little time and started to think, what should we do next? We need to remember the patient's chief complaint was tearing for almost half a year, and the patient is under general anesthesia. A lot of ideas came into my mind, including closing the wound and waking the patient, because this might be the cause of his tearing problem, or send the specimen, which we don't know what is the nature of this specimen, for frozen section and wait for the results, or continue as conventional external DCR as we planned for the patient, or excise the lacrimal sac, which could be the source of this lesion, or do probing and irrigation despite the patient is under general anesthesia, or any other options from we can think. I don't know if any of you has an idea what will be the best thing to do in such a case, if we would like to discuss it now or at the end of the case.
We can share very quickly, Dr. Osama, like 30 seconds if you like. Do you want to ask somebody
Yes.
specifically?
Yeah. May I
No,
comment?
anybody. Yes, please.
Yeah. I think you should have done probing before you incise. I mean, you were not sure this is a mucocele, but probing would have given an idea if you have the probe inside the sac or not.
Yeah,
I mean, it's a deceiving case, of course. Yeah.
Okay.
But
thank you, Dr.
but
Sharif.
at this, thank you. At the situation now, I think you should have this mass that you extracted examined pathologically. and not
Yes.
necessarily through frozen section, maybe later on, and you decide on it on a second session. Thank you.
So you might close the wound and wait for the results, which is choice A.
Yeah, this is what I would have done.
Okay, thank you.
Dr. Osama, I may add just a few seconds. Sometimes
Dr.
a brave
Farzad,
surgeon is the
please.
surgeon that decides. A brave surgeon sometimes is a surgeon that decides to stop the operation rather than continue the operation.
I
So
agree.
it needs more courage actually there than continue the
To
operation.
continue.
And
Okay.
we know that if you think during a DCR, if you are seeing some unexpected mass lesion over the lacrimal sac, it's essential to stop the operation and not just continue and do actually osteotomy. It's a rule for all colleagues here. And I believe probing irrigation test is helpful at that moment when your patient is under anesthesia. So we would hear more about this case from you now.
Okay, so what I did let's go back. What I did as you both said, I did the probing exactly, and I found the proximal lacrimal system, the upper canalicular system is totally patent. So after that, here is the probe. So after that, I did irrigation, which showed early sac distension. Then the sac opened with a mucopurulent discharge. Now the sac is open. So what we do next? Here is the mucopurulent discharge coming out from the sac. And as I said, the sac after irrigation, it enlarged in size. Okay, and after that, later on, it ruptured or it opened with me during the surgery. So what to do next?
Do you want to continue, Dr. Osama? Because we have now just 3 minutes. And I feel we need to finish it in 3 minutes.
Okay, so what I did actually is I excise the lacrimal sac. Why? I was not sure about the nature of the pathology of the patient. So I took the lacrimal sac completely out in toto. And then here is the picture after total excision of the lacrimal sac. And then I continued as an external DCR with intubation. Here are the tube, as we can see, both tubes, Surgicel over the tubes, and skin enclosure. Of course, I sent the pathology. Here is 3 weeks after the surgery, no problem. The histopathology came a week later, and here is the report. It was a single round mass measuring 1 centimeter by 6.6 centimeter by 0.3 centimeter. It was formed from a mixture of spindle cells mixed with inflammatory cell infiltrate composed predominantly of plasma cells and histiocytes. So, and here is an important note in the histopathology. Ziehl-Neelsen stain was negative for acid-fast bacilli. It was not TB. Here, a low power magnification showing the total excision of the mass with the capsule intact. And here another stain. So the diagnosis came back as benign spindle cell pseudotumor. Actually, I looked at for this tumor or benign pseudoinflammation in PubMed and National Library of Medicine, and unfortunately, I did not find anything around the orbit, periorbital eyelid, orbital benign spindle cells. No results were found. I found one article from Lewis Jr. in the head and neck pathology saying that it is a variety of disorders that can vary from malignant or others are simply benign or reactive, but most spindle cell pseudotumors reported in the literatures are associated with Mycobacterium, a variant of TB. In our patient, we had a negative Ziehl-Neelsen stain, so it is not a TB. The patient is doing, here is the lacrimal sac biopsy, and it showed features of acute and chronic inflammation with no evidence of malignancy. The patient is doing well after 9 months of the surgery with no complaints. And as we can see, the DCR tube is still in place. patient is happy, and we solved his tearing problem and also took out this rare tumor. I would like to thank my colleagues in the hospital, Professor Musa Labadi, he's the professor of pathology, Dr. Tal Arach, he's a pathology resident, and our ophthalmology resident, Dr. Isra Asfour. Thank you all.
Thank you very much, Dr. Osama. So we'll be back to you. And I would like to ask our next speaker, Dr. Walid Abdullah, for starting his presentation. So I would like to ask our audience, please write your questions in the chat box or in the Q&A box. So we will come back to your questions after all presentations. Can you stop sharing, Dr. Osama, please? So.
Yeah. Yes. Okay. Sure.
Dr. Walid, please.
Just 1 second. Can you share?
Yeah,
Yes,
we
okay.
can see.
Okay.
Okay, perfect. So,
hello,
Dr. Walid,
everybody. You can hear me?
yeah, we can hear you.
So, okay, how can I? Hello, everybody. I'm very honored to be with you all. I have a case here I want to share with you, which is a multiple cranial nerve affection. So this case, as we are all facing cases with cranial nerves, we're usually familiar with the third, fourth, and sixth, but also when we have an affection with the trigeminal nerve for the facial sensation and the facial nerve for the motility of the face and affecting the corneal cessation and corneal closure, at that time it will be a bit more tough. So my case here is an Omani guy. He is 35 years old. He has a benign big brain tumor, and this brain tumor was excised about 8 months ago. He is complaining now from redness, some pain in his eyes, inability, photophobia, and he cannot close his eyes, and he has also diplopia. This is the patient. We have the whole face. We got the consent of showing the whole face because he has symptoms in his face as well. As you can see, the big esotropia, the redness, ciliary injection, and also he has diminishing in the facial sensation, motility. You have this deviation of the face toward the left, and he has sensory hearing loss as well on the left ear, so he can hear only with one side after the surgery. So by examination, the visual acuity was affected, not only by the refractive error. Ciliary injection was there, punctate epithelial erosion in the middle 2/3 of the eye, the lower 2/3, with exposure keratitis, corneal hypothesia with the starting neurotrophic ulcers as well. The pupil was, but everything else was normal. So this is how he looks when he tries to close the eye. Even with force, he cannot close properly the both eyes. So away from that, the motility also was affected. Esotropia, distance more than near, showing bilateral 6th nerve palsy as well, with fixation of the left eye. This is the orthoptic evaluation. And going after that with the fully investigation, the neurological surgeon was approached also. He said that everything is stable, no more things to be done for the patient. So the patient is totally stable from the neurological point of view. Diagnosis was made that now we have affection of the 5th, 6th, 7th, and 8th cranial nerves, and the 6th cranial nerve was affected for both eyes, with more toward the left eye, as you can see in the photo. So lid lag was there, exposure keratitis. We prioritized to correct, of course, the most dangerous one, which is the lid lag. Conservative treatment was done already, so, and even temporary tarsorrhaphy was done. So the gold weight was chosen to be the next step. So now we went for sizing of the proper size, when the proper weight, which is going to be making the eye closed. The proper weight was chosen. This is the sizes, the different available sizes with 3 holes, which is used to fix the gold weight to the tarsus. The patient has problem with sleeping with general anesthesia, so both procedures with the gold weight, which is normally done under local anesthesia, was done under local anesthesia, and also the procedure for the squint was done under local anesthesia as well. So lid crease was done, and the gold weight was put on the tarsus directly, fixed with non-absorbable sutures through 2 holes to the underlying tarsus. Orbicularis oculi was sutured, so subcutaneous was done to prevent the protrusion and also for cosmetic purposes. Then the skin was closed properly. This is how he looks, proper closure. This is just immediately during surgery, and this is after surgery with almost 1 week, and this is the 1 month follow-up after. So the squint surgery also was done, and again, absorbable suture was rejected, recession and resection. And this is the picture after doing the squint surgery he has a very small desirable overcorrection, and the face turn was much less. And this is you can see the ciliary injection subsided, and all the signs of exposure was not there after the procedure. He can close properly, and he doesn't have any double vision with complete closure. As conclusion, so 6 nerve palsy can come, showing on the nuclear level multiple cranial nerve affection, when multiple causes can cause that, when they are affecting the pons level of the nuclei, with the pontine paramedial reticular formation and the fasciculus of the 7th nerve. This is a case actually of acoustic neuroma, as it was shown with bilateral 6 nerve palsy, was affected also by the raised intracranial pressure. Can be also a differential diagnosis of nasopharyngeal tumors or intracavernous part if it will be affected. This case was affected the 6th nerve, so esotropia was there, limitation was there, and face turn was there, and the head posture, facial muscle weakness was there, and the facial sensation was subsided. So we're supposed to manage all those through the 2 ways, which is fix first the lid lag with the gold weight after using the conservative measures till he will be ready for fixing the gold weight, and then fixing the alignment as the lid lag is the priority. Thank you for, I hope that I didn't take so long time, and I'm open to any discussion. Thank
you, Dr. Walid. Great presentation. I was just curious if you have any MRI to show us.
Actually, he did that. He was coming from a different country, and this MRI was there as a CD, but no, it's not here in the presentation.
Okay, thank you very much. We will come back to you. So I would like to ask our next speaker. I'm not sure if Dr. Feiruz is here. Maybe our Dr. Mohammed, can you inform us if we have Dr. Feiruz with us? Otherwise, I may go for Dr. Mehdi. Dr. Fenry, can you please unmute and share your slides? Hello. Dr. Fenry.
Okay, it's okay.
Yeah, we can see your slides now and your voice.
Yes. So thanks everybody. Thank Dr. Mohammed. Thank Dr. Farzad. My case is a case about acute exophthalmos with the history of vascular orbital anomaly. So as you know, vascular orbital anomaly is very polymorph, and we have the last classification would distinguish vascular malformation and vascular tumors. And our case is about lymphatic malformation, and with the assessment, with the clinical, radiological, and histopathological examination, with the particularity of risk of hemorrhage. So my case is 20 years old. He has a history of surgery of orbital vascular anomaly in 2000, and with no details for the anatomopathology. And in 2017, he was exophthalmos treated medically. When he comes to our office, he had a very severe visual acuity loss with exophthalmos and chemosis, with corneal ulceration, with reduction of ocular motility, with very increased intraocular pressure, and dependence with normal, with no papillary edema. So when we asked the patient for his picture just before the exophthalmos, he was almost normal. And for this patient, we start with medical treatment by antibiotics and steroids. And we ask for imaging, urgent imaging in emergency. And this for this patient, the first question, should he do TDM or MRI? With the history of vascular lesion, of course, we prefer to do MRI. And when we look to the MRI, we have multiple diffusal infiltrating cyst, which is very typical to the lymphatic malformation. And here is in the coronal section, the multiple cyst was evident, but the particularity of this case, when we look in the deep on intracorneal lesions, we show that we have a big cyst with a fluid level, which explain the acute exophthalmos in this patient and explain all the symptomatology. In this case, the second question, should we continue with the medical treatment? Should we decide for aspiration of the acute hemorrhage cyst with the surgical approach, or should you do it with non-surgical approach but with radiological control? Should we decide for aspiration and do injection of sclerosant agent at the same time, or should we decide for the surgical removal of the cyst? This is the first question that we ask with this kind of patient. The second option is, should we decide to manage the effect of the hemorrhage and not to treat the hemorrhage itself, manage the effect of the hemorrhage that causes hyperpression, the equivalent of orbital compartment syndrome, or should we decide for this case orbital decompression? If we decide for the orbital decompression, which ward should we decompress and which kind of approach? We decided for this option to do orbital decompression in emergency with a conjunctival approach. We decided to do medial wall decompression with a conjunctival approach with no access to the lesions, and the evolution 1 week postoperatively, we have improved of the exophthalmos and the reduction of the chemosis, and the evolution was going too slowly. To improve the chemosis, we decided to do blepharophy, and only 15 days postoperatively, we have the improvement of oculomotricity, and only after 1 month, we have the improvement of the visual acuity and a better improvement of the exophthalmos. And she had only at the second month, the total recovery of the visual acuity of the oculomotricity problems, and the increased ophthalmic pressure. And for this situation, after 2 months, another question that we can ask for this patient, should we go with the sclerotherapy, or should we stop in this for this patient with no sclerotherapy after 2 months and after the total recovery, as we see compared with the photo before the exophthalmos. So for the discussion, I think the location and extension of the lymphangioma, mainly lymphatic malformation, is very important for the assessment and the management. As you know, the management is based on observation, sclerotherapy, systemic therapy, or surgery. For the deep lesions, it's the most challenging situation with the risk of functional complication and the risk of the surgery, the risk of sclerotherapy, because the excess of the lesion is very difficult, and we should decide between conservative approach or treatment. Of course, part the emergency, and in case of emergency such as this case, what's the best therapeutic protocol? This is the main point to discuss together. So in conclusion, lymphatic malformation is sometimes very challenging, the deep lesion mainly, and orbital decompression, in my experience, is very helpful in case of complication. And also we developed a new concept of sclerotherapy with low pressure sclerotherapy based in a simultaneous decompression at the same time as sclerotherapy. And this is for the complication is very important and very helpful alternative for this kind of problem. Thank you.
Thank you, Dr. Mehdi. So we'll come back to you. And now we will go to Dr. Sharif Elwan. Hello, Dr. Sharif.
Yes.
Dr. Mehdi, can I ask
Hello?
you to stop sharing your presentation so we can have Dr. Sharif's presentation? Thank you. So I believe we have good time
Okay.
for discussions.
Yeah, sure. Thank you very much for the invitation and for moderating the session. And I am going to go through 3 cases, if you allow me. I remind you all that common things are common, and this is what we've been taught as young medical students, and all through our careers, we've been teaching our students and fellows to think of common things first. However, this is my first case. A young girl of 22 presented with protruding eyes with history of bilateral 3 periorbital steroid injections with the doubtful protrusion progression. She was an emmetrope with visual acuity of 1 bilaterally, high intraocular pressure, exophthalmos, as you can see, more on the left side. Otherwise, she was normal. This is my patient from different views, and she had no symptoms of hyperthyroidism, no neck signs. B-scan and MRI showed thickened extraocular muscles, and here are the measurements. When we investigated her, she had a normal free T3, normal free T4, normal TSH, normal anti-thyroglobulin antibodies level, and normal TRAB, which is the thyroid-releasing hormone antibodies, which is now known as the major player in Graves' disease. These are the investigations. So it came to my mind the rare or very rare diagnosis of euthyroid Graves' disease in the absence of all classic signs of Graves' orbitopathy, with normal thyroid profile and no signs of hyperthyroidism. The management is controversial. Systemic steroids have been used, systemic monoclonal antibodies in particular, tocilizumab, which is Actemra, used in treatment of the COVID, periocular steroids, other systemic immune modulation, and finally, some of endocrinologists suggest thyroidectomy. So this is the first case, which is euthyroid brevis orbital. My second case is a gentleman of 57 who came complaining of deviated globe of long duration. He was living with pets and with a history of motor car accident 20 years ago, a neurosurgical intervention to restore his frontal bone. On examination, he had a very big cyst, medial, pushing the left globe laterally with severe diplopia. In the OR, I aspirated this cyst for decompression and the bloody fluid came out. The CT showed this very big cyst, which is almost 1.5 times the diameter of the eye globe, with this squaring that you can see, with bone resorption in 3 of the orbital walls, indicating long duration. And I went in transconjunctivally, and after decompression, I excised this cyst. Of course, I thought of hydatid cyst due to the history of living with pets, but when I aspirated, I started to go into other ideas. The pathology came up with a surprise, a fibrotic wall with lining of cuboidal, partly flattened epithelium, with underlying stroma, with aggregates of lymphocytes, foci of vascular channels, and the aspiration content was hemorrhage. It's a hemorrhagic fluid, microscopically showing no scolices, only blood. And this is the report. And the report concluded that this is a pseudoreferous cyst, which is a mole cyst, as we all know. Mole pseudoreferous cyst is regularly presented due to blocked apocrine sweat glands found on the margin of the eyelid, a solitary dome-shaped papules filled with clear fluid, trans-eliminated well. So this is a rare case of gigantic pseudoreferous cyst. And my third case was a 7-year-old young girl who came complaining of a lid wound and a very other strange complaint that one of her color pencils disappeared. This was the report of the parents. On a 3D CT, I found the pencil, and this is the surprise. This is the site of wound where the parents were complaining with some upper lid cellulitis. And here's the pen. It starts in the orbit, pierces the floor, goes into the pterygopalatine fossa, and goes near to the second vertebrae, second cervical vertebra. This the pen. We went in, I widened the wound, and I extracted this pencil. And I remind you that intraorbital foreign bodies have an individualized decision to operate. We don't have a consensus on this. However, the risk of surgery versus the risk of intervention, as you could see, this could have threatened their life going into the upper vertebral column. Possible complications like infection and inflammation, being chronic fistula formation, neurologic compromises, and mechanical restriction. It depends also on the nature of the foreign body. Being organic, you have to remove. Inorganic, if it is anterior in the orbit and accessible, it's okay. If it is posterior and organic, probably you have to observe. And this is what I found, an intraorbital pencil. So the unexpected apple that I cut to find it an orange was euthyroid Graves' disease, gigantic pseudoreferous cyst, and intraorbital pencil. The take-home message from my presentation is number one, never rule out a rarity. Consider common diagnoses first, think of rare alternatives afterwards. Patient history telling is sometimes missing significant events, and the investigations complement examination. Thank you very much.
Thank you, Dr. Sharif. Great presentation and very interesting cases. So we can now go for question and answers. I'm not sure if we have any questions. I'm not seeing a panel for questions. Maybe our tech actually colleagues can inform us. Do we have any questions from the audience, or we can go to the panel and ask our questions? So I will start from, if you let me, from my talk on Sando, secondary to GPA. If there is any comments from our colleagues here, I will be happy to answer. Otherwise, I will go to next talk.
I have one question for you, Dr. Farzad.
Sure.
I read that Wagner's granulomatosis has changed name into granulomatosis with polyangiitis.
Yeah.
It's not
Correct.
anymore called Wagner's granulomatosis.
No, it's GPA.
But I don't
now.
know why. We've long known that there is angiitis with granulomatosis. Why the change of name?
I'm not that much sure, but we know that now we classify this type of the vasculitic lesions under the umbrella of GPA into 3 types based on the actual staining of the anti-nuclear antibodies. So maybe one reason is not the reason is that what we understood from the triad of the Wegeners is not for all of these subtypes. Although all of them have angiitis, but some of them have, more distant lesions, and they have different kinds of ANCA actually presentations.
Thank you.
Any more questions? So, Dr. Osama,
Yes.
it was interesting to actually to understand how to deal with an unexpected lacrimal sac mass during operation. So we understood one take-home message as if you suspicious or you find some lacrimal sac malignant lesion, you may stop the operation. And I'm not sure if you find something that persuaded you to do for dacrocystectomy and then for osteotomy. This is my first question. And I will go for the next one, that's for the diagnosis of that lesion.
Okay. For the first question, there was no signs of malignancy. The lesion looked totally benign, circumscribed, well demarcated, not telangiectasia. So I thought this could be benign rather than a malignant lesion. So that's why I decided to take it in total and continue the procedure or continue the surgery. If it was malignant or if there are malignant signs or symptoms, yes, of course, I would take an incisional biopsy and abort the surgery or discontinue the procedure. The other thing, the origin of this lesion, I even talked to the pathologist, whether it was the lacrimal sac or the surrounding area, namely the orbicularis muscle. We could not define the origin of this benign lesion. So even though I decided to take the lacrimal sac out because it could be the sign, or the source or the origin of this lesion. So combining, taking the mass out in total and taking the lacrimal sac and also sending it to pathology. And the pathology came as just acute and chronic inflammation with no malignancy, was reassuring for me after the surgery. So basically, this is what I thought at the time of surgery. I had the option to stop the surgery and come back for later on and wait for the biopsy. But I thought first, this is a benign lesion, best to take it out and then to continue. The other issue, the patient symptoms started before the onset. As I said in the beginning, he came after 6 months with this mass, but he already complaining of epiphora. That's why I also elected to continue with the conventional DCR.
Dr.
I-
Farzad, I have a question.
Oh, yeah, sure, Dr. Mahdi.
Yes. Of course, we discussed about the per-operative situation is a difficult situation, and this point is very important to discuss. But I think another learning message is the assessment of this patient. For me, if there is any abnormalities in the examination or in the history of the patient, imaging is very important.
Yes.
As you know, I'm
Of course.
very attracted to CT DCG.
Hello, Dr. Mohammed.
For this patient, it was probably very helpful to have pre-operatively a CT DCG for a better decision per-operatively. Can be
Well,
very.
yeah. Well, Dr. Mahdi, for me, as if you see the pictures, it looked typical as a dacryoceal. There was nothing different to suggest a dacryoceal other than there were no reflux of mucopurulent material, and this could be due to a patent internal punctum or valve Rosen-Miller. Otherwise, his examination, his medically healthy, his presentation, the color of the skin, nothing to suggest that there is a mass underneath the skin. So it was just once we opened the skin that I noticed there is something that doesn't look right.
One point, probably, in my experience, when I have this kind of situation with a good exploration of the dye test and irrigation test, if there is no obstruction, no dye test retention, and a very good irrigation test, for me, it's a good indication for imaging before deciding the surgery. I know that is the typical situation, but sometimes some details start to be with
Missed.
some question we should answer. It's better to have a better assessment before surgery.
True.
I have one more question to Dr. Sama as well. Is the palpation didn't make you feel something different from the cystic feeling, like firm to hard, since if palpation of the mass
No,
itself?
No, just felt smooth and round and compressible also. Can compress it, but nothing came out from the lacrimal sac. So even palpation did not give me any clue that could be an underlying mass. It was really strange for me that I found this mass just after I incised the skin. Nothing in the history, nothing in the examination. Otherwise, I would go further for imaging and evaluate him with further testing, MRI or CT scan, but nothing at all in the examination suggested that it could be a mass.
So we understood that we had a challenging situation. So although I would like to emphasize the importance of the pre and intraoperative diagnostic procedures to make sure that everything is like a usual case. In any case with atypical presentations, or we cannot actually interpret why this is like that, why it's like firm. So imaging is very helpful in these situations.
Yes.
And in the case that we found everything was normal, but during operation find something is inside or overlying the lacrimal sac wall, as Dr. Osama showed us, it's really critical to decide how to proceed. To me, if it's like a tumoral mass inside or overlying the lacrimal sac, I will start operation and will just take a biopsy. I think Dr. Osama considered that, but when he found that we have a problem with the lacrimal sac, it's like open, and there is a risk for cellulitis or something, and he realized we need to do something for repair or removing that. So I think it was because of that, and we know that if we have tumor of the lacrimal sac, DCR is not a good option. We should do dacrocystectomy. But I will do that just after I have received the pathology confirmation of what kind of a tumor I'm dealing. For example, if you have lymphoma, you do not need to remove the sac. You don't just go for radiotherapy and chemotherapy. But if you have other tumors that I would like to open the discussion here about the diagnosis, you beautifully showed us how it's difficult to interpret the diagnosis based on the pathologic report. So I'm not sure if it was like a mycobacterial solitary, actually pseudo-inflammatory lesion, because for this type of lesion, we need to confirm it's mycobacterial. And I didn't see anything to confirm it's like a mycobacterial infection.
No.
So based on the description first, because of the spindle cells, and despite it was CD30 minus, it was not positive in this tumor, but solitary fibrous tumor would be a good consideration. We know in some cases with solitary fibrous tumor, we have CD34 negative situations. I would like to ask if you checked for BCL2 or CD68 or other actually markers for SF?
Yes, I think we did, and let me share my screen again if I can.
So while you're sharing, I would like to inform my dear friends and colleagues that fortunately Dr. Mohammed gave us like 10 more minutes at least, so we have good time for discussions as far as we have good messages for our audience here. So yeah, I think the diagnosis is critical for this patient. If it's like a sarcoma, we know that this is a picture for some kind of sarcoma, so it's not, we cannot actually
Is my
just,
screen
no, we cannot see your slide here.
Can I share it? Just 1 minute.
Yeah, take your time. So while you are sharing, do we have any other comments for Dr. Osama's here? So after Dr. Osama, we'll go to Dr. Walid.
Yes.
Yes. Yeah. Can you see it now, I think?
Yeah, we can see your slide here.
Okay, so let's go to this slide first. Okay. So here is the histopathology. CD68 was positive in this patient, and the spindle cells were focally positive for the smooth muscle actin, and they were negative for CD34. They were also negative for the neurofilament. They were negative for CK7 and negative for ALK. I reviewed the histopathology with the pathologist who I mentioned at the end of my presentation, actually twice, at the time of reporting and the second time before deciding to present this case to you. So we at both times we reviewed this case. He still insisted on the diagnosis of spindle cell inflammation or pseudotumor. Ziehl-Neelsen stain, which is associated with spindle cell pseudotumor, were negative. Yes, if you go to the literatures and search for spindle cell pseudotumor, all the reports, as I said, they were associated with mycobacterium, but no clinical features or no systemic features in this patient to suggest TB. So it could be just an isolated spindle cell proliferation. And if you, and here are also other stains that I came. These are also the positive CD68 immunohistochemical stains that highlights the histiocytes. And here are another higher magnification view. So the pathologist has no question that this is a spindle cell pseudotumor. What is the source of this pseudotumor? We cannot tell. What is the source of origin? Was it the surrounding tissue or the lacrimal sac? Still, if it was from the lacrimal sac, I will be happy because this could be reported. I looked into lacrimal sac tumors and there is no spindle cell pseudotumors coming out from the, at least there is no reported cases coming out from the orbit or the eyelids or from the lacrimal sac area. So unfortunately, we couldn't localize the origin of this. It could be arising from all the trauma or all minor infection. We don't know the origin actually.
So
Dr. Farzad, I have a comment.
Based on the intraoperative photos you showed us, I assume it's like a lacrimal sac tumor, because when you remove the tumor, your lacrimal sac was open. So I assume it was like that. And I would like to mention that your pathologist assumed that the inflammation is because of the nature of the disease. To me, I've seen lots of cases with, lacrimal sac tumors, including SFT, solitary fibrous tumors. I've seen many of them. So
Yeah.
the inflammation is not for the nature of the tumor. It's because of the nature of the location of that actually organ. Yeah, because when you have chronic inflammation, chronic stasis of the actually tearing over there, you will have some chronic inflammation. It's not because of the tumor. So we need to focus on the, we need to focus on the,
continue to Farad,
No, I'm done.
And this patient, there was no history of, in this patient, there was no history even of inflammation, no skin tenderness, no redness, nothing.
Exactly.
Just the swelling coming out over
so
2 or 3 weeks.
It's not like a pseudotumor. It's like just a tumor. So one of our colleagues
just
wanted to
small comment.
Yeah, Dr. Sharif,
Yeah. To my mind, if you can share the histopathology photo once more, the swirls of spindle cells looks to me like a rhabdomyoma, and being chronic inflammatory this one
the first one, second one,
the one with silver stain.
Okay.
You see the swirls look like a mass from the skeletal muscle, like a rhabdomyoma. I wouldn't say it's a sarcoma because of the clues that the pathologist gave, but it could be originating from the overlying orbicularis muscle, especially with your comment.
Exactly. This is what I had in mind. It was not originating from the lacrimal sac, but I took the lacrimal sac just in case it was a source of the region.
Okay, thank you very much.
You're welcome.
Thank you very much. It was very interesting, Dr. Asama, with many interesting points in that. So we can go to Dr. Walid for the interesting case with multiple cranial nerve pulses.
I have a question, Dr. Walid.
Yes.
Yeah. Thanks you for your result. Very interesting case, and you have a very good result. In my experience, when you have 6 nerve palsy and 7 nerve palsy, it's very difficult to manage. But for the esotropy and the strabismus, how do you operate it with recession and resection muscles? And what's the improvement of the oculomotricity in this patient?
we are behind the time. If you can just have the last question, this one.
Okay.
I didn't go deeply with the, I didn't go deeply with the correction of the strabismus as the part is more toward the oculoplastic part, but there is a rule, of course, of putting the patient for transplantation of the transpositioning of the whether half tendon or full tendon of the if the eye will not cross the midline. But if it is crossing the midline, we do resection for the medial rectus and lateral rectus and see how is it, and aiming for some little overcorrection. As you saw, there is a very small exotropia. So this is going to make him fuse. The idea is to overcome the binocularity. His general condition is tough. He is not tolerating the general anesthesia. He cannot do adjustable sutures because he is wheelchaired, by the way. So the condition was more tough towards correcting and leaving him with single vision. This is the aim, and some small overcorrection was aimed, but it was good that the motility, once it is correct over the cross, they can cross the midline. We are going for resection and giving the chance first and see how it's going to be. I think this was the question, right?
Yeah.
So, Dr. Mohammed, how much time do we have, if any?
We don't have any. We already crossed the time.
Okay, so
You
we
can
have
conclude, yes, please.
we have used all the time that you gave us, yeah?
Yeah, and 15 minutes more.
Okay.
We started late, dear Muhammad.
Yes.
Very generous, Dr. Muhammad. Very generous. Thank you.
This 10
We
minutes
started
already
today.
taken from Dr. Fairuz. He didn't be there. That's why.
Okay.
Thank
It
you,
was a
Dr.
very good
Farzad.
and
Thank you,
instructive
Dr.
session.
Sharif, Dr. Mahdi, Dr. Walid Abdullah. Thanks,
Thank
Dr.
you.
Walid.
Thank you for all.
Be with us.
Very much.
Thank you,
Thank
Dr.
you all.
Farzad. Thanks a lot.
you.
Thank you, everyone. Thanks a lot.
Thank you.